Hello, this is Dr. Peter Derman. I'm going to talk today through a full-length case of an endoscopic discectomy. And I'm joined today by a special guest, my son. What's your name?
Noah.
Noah, that's right. And how old are you, Noah?
5.
5. Noah, this is a patient. She's a 34-year-old lady who had pain shooting down the back of her right leg that was going on for months and months. And she tried everything to make it get better, but it was still there. And she couldn't feel better. These are her x-rays. The one on the left is her from the front. The one on the right is her from the side. And you can see she's not standing up straight because she's in so much pain.
Starting right there, it curves.
Yeah, exactly right. It curves. This is her from the side. And then what you're going to see next is her MRI. And what you see on the left side is that bottom disc is bulging out and really pushing on her nerve. Do you know what the discs are? So in the spine, there's a whole bunch of bones, and then in between each bone is what we call a disc. And the discs are the shock absorbers between the bones. And in some people, the discs get worn out, or they bulge, or maybe a piece breaks off, and it pushes on the nerve. And those are the nerves that go down your leg, and that can cause them a lot of pain.
Dad, you putting a dot there?
Yeah, exactly right. So I'm putting a dot there. I'm using the x-ray in order to find the perfect spot right over that disc herniation that I'm going to go in and remove it. And so we use the x-ray in the operating room to figure out exactly where to go.
What's that thing?
That piece of metal? Basically on the x-ray, you can see the metal really well. So that's what I use to plan out where I'm going to go. And what you're going to see is, on this x-ray here, on the far right, there's that little black line pointing toward where the disc is.
Yeah?
And that's how I plan out where my incision's going to be to get down.
Yeah?
You can see there's a big team in the operating room. There's a lot of us who have to work together. So there's me, and those legs that you see, those are from the x-ray tech. And then there's an anesthesiologist who gives the medicine and keeps the patient asleep and comfortable. This is me giving a shot of some numbing medication just to prevent them from having any pain when they wake up.
Why do we not see anything in there?
That's a good question. The medication that I give is clear, so you don't see anything. It's like it looks like water, but it's numbing medicine.
Why is also the tube thing not going down?
It is. I'm just going down gradually.
Okay. You're putting it in different spots so it doesn't go down totally?
Exactly right. I'm spreading it around in different places. So sometimes these patients actually can be awake during the surgery, and sometimes they're asleep. But either way, I like to give this medication so that when they wake up later, it's all numbed up and they don't have a lot of pain. In fact, most of them go home within a couple hours of surgery.
Dada?
So now what's going to happen is we're going to do something called a block, which is I put even more medication around that area to keep it nice and numbed up so the patient's really comfortable.
Is that the x-ray machine?
That's the x-ray machine. We call it a C-arm or a fluoroscope. And that's the x-ray technicians on the left. And the lady in front of me there, she's called a scrub tech. She's the one that hands me all the instruments and everything like that. And the anesthesiologist you can kind of see in the back behind all those clear drapes. And then kind of behind me over there, that's the physician's assistant. And so he helps me and makes sure the surgery goes really smoothly.
And that's Daddy?
That's me. And you can see I'm actually wearing a camera on my head. I don't usually wear that. I just did it for this case so that you could see these views like this.
And that's also how you make a video?
That's how you make a video. And so what I'm doing now is I'm targeting where I'm going to put a little bit more medication. I do something called an ESP block, erector spinae plane. And that gives people even more comfort after surgery so that they're really comfortable. And we also don't have to give them as much medication, like sleepy medication, during surgery because everything's nicely numbed up. But I use x-ray to make sure that everything is precisely where it needs to be.
You only can see the whole, when you look at the dot, because that's the only spot where you use the surgery.
Right where that first dot is where I'm going to do the surgery. So this is me. You see the plunger is going to go down. This is me putting more medication down.
Why do you put so much medication?
That's a good question. If you give them the numbing medication before surgery, we actually have studies that show that they have less pain after surgery. So I like to make sure that they're really comfortable. You can see I spend a good amount of time numbing everything up so that the surgery is not painful and they have less pain afterwards. So this is a scalpel, and you see I'm going to make a little incision there.
A little hole?
Smaller than a dime. And that's the incision. And that is the hole through which I'm going to put my camera. And I do this surgery with a camera. And so I make that little incision, and then this thing is called a dilator. So it's a narrow thing that just goes between the muscles and then down to the bone. And that's going to be my tract.
That tube thing kind of looks like a straw.
It does look like a straw, that's right. So we use X-ray again, just to make sure it's exactly where I want it to be. Because when you're doing this minimally invasive stuff, you've got to be very precise about where you put everything. So then there's another dilator that goes over the first one and just spreads the muscle out of the way. You know, the traditional way of doing this, Noah, is to make a much bigger cut than this, an incision. That's a little tube that goes over it, see? You make a bigger incision and cutting and burning the muscles off the spine. And that's why people have a lot of more pain after spine surgery. But this endoscopic surgery with the camera, you can see I didn't cut the muscle or anything. I just made a little incision in the skin, and then we're using these dilators to just gently spread the muscle out of the way.
I also can see a red little light.
Yeah, that light is actually a laser. Good point.
Does the light laser not say like a shoot laser?
It doesn't cut anything. But the laser, the laser is what helps the X-ray tech figure out exactly where he is, so everything's lined up. So you can see if he points the laser, if the laser is pointing at the incision, then he knows everything's where it's supposed to be. And there you can see those dilators and the working tube pointing right at that bottom disc space where that disc herniation is.
Mm-hmm.
And so what I'm going to do is I remove those initial dilators, or the straws that you saw.
Mm-hmm.
So I'm going to take out the inside ones, and what I leave is that tube.
There's more than one straw?
Yeah, but the outer straw I leave in place. It's called a working cannula.
Mm-hmm.
And you'll see this is the camera. That's called an endoscope.
It has a light right there.
At the end of it, exactly. So it has a light, and it has a camera. And I place that in through the working cannula.
Why did you turn the lights off for a second?
We turned down the lights so I could see this screen, because actually, rather than open everything up and look down into the patient, I put the camera down and I do the whole surgery on this high definition screen.
Ooh.
And so if we turn the lights down, it helps me see the screen a little bit better.
And then what are those other medium-sized one and a little one for?
They help other people in the operating room see.
Mm-hmm.
In real life, when I see the screen, it's much higher quality than this. It's just because it's filmed from the camera on my head.
Oh.
This is what it looks like. So this is me with the camera looking down that tube.
What's all that mushy stuff?
All that mushy stuff is just a little bit of fat and a little bit of soft tissue that's over the bone and the area where the disc is. And this whole area that we're looking at here, it looks big, but it's like smaller than a dime. It's smaller than a centimeter.
Wait, that's a grabby thing that I see in all of your videos?
So that is actually, this tool, I do have a grabby thing and I'll show it to you. This tool is called a cautery. And what it does is it shrinks tissue, and it if there's any little veins that are bleeding, it stops them from bleeding.
Is it like a vacuum?
It actually uses electricity. And then this is that grabby thing. That we call it the grabber. And what I'm doing here is removing just any little wisps of soft tissue. Yeah, you'll see I move just a little bit of soft tissue, but actually, very, very little. And what I'm looking for is to find the edge of that bone there, because the edge of the bone, that's kind of what I reference off of. If I find that and then I know where I'm going to get in, because the disc is somewhere below that.
Why is it so hard to get it out?
To get it out, it just takes a little bit of time. But soon what you're going to see is the edge of the bone of the spine called the lamina.
Because it's a little tool?
Yeah, so the tools, very good point. The tools, they look big on the screen, but in real life,
it's really small.
It's really tiny. It's like a few millimeters.
But it's also really long.
It is long to fit down exactly right, to fit down the...
Small but long.
To fit down the working cannula and in the endoscope. And so what you're going to start to see is on the right side of the screen, every once in a while you'll see a little bit of that bone. Just to get you oriented, the patient's head is on the right,
So
off the screen to the right.
So
the
you
patient's,
can't see it.
No, it's way far away. We're at the very base of her low back. The patient's legs are to the left. The right side of the patient, and we're on the right side, is the bottom of the screen, and toward the middle or to the left side is the top of the screen.
And the surgeon is in the leg on the left side?
On the right side. That's why I go on the right side for this one.
Oh.
And so we got to remove that disc herniation. So what I'm doing here is I'm cleaning off that bone, which is kind of that white stuff that's going up and down on the screen.
So now you're not using the grabby thingy anymore?
I kind of go back and forth between the grabber and the cautery, which now what I'm doing is I move down a little bit, just ever so slightly below the bone, and there's something called the ligamentum flavum. Can you say ligamentum flavum?
Ligamentum flavum?
So it's not a bone, it's like a soft tissue, kind of like a ligament.
Like the same thing that we just saw?
Similar, but right under the ligament is the nerves.
And you want to get under there?
Exactly right. So what I do is, fortunately, I don't have to remove really any bone at all. And that's one of the nice things about doing this with the camera, because it's so small I can get in through an existing opening in the bone without having to remove any of the bone. But this tool that I'm using, which we call a punch, allows me to get safely through the ligament.
Well, once you get to the vessels, you use the heat thingy?
Exactly, the cautery, so that there's no bleeding. And usually the bleeding for this surgery is like just a few drops.
Mm-hmm.
And so I'm very carefully, you can see the...
I did see some blood when you just made a hole.
Yep, but only a little bit, right?
Yeah.
And so you see this ligament, see how it's starting to get thin? See how it's kind of gray right there in the middle there?
Yeah, is it bone?
No, underneath there is where the nerves are. Watch, I'm going to poke ever so gently a hole.
Oh.
See that hole?
Yeah.
So now what happens is the fluid, the water from the camera, see how everything's shaking? The camera uses water to pump into that area, and that water is pushing the nerves away, and now I can remove just a little bit of that ligament. This whole thing is like, that instrument is like 3 millimeters or something. And so I'm just making a little opening, which will allow me to get down and see where the nerves are. You see that nerves? You're starting to see them underneath.
It looks like a big, because the camera.
Yeah, everything looks big because of the camera, exactly right. But in reality, everything's really small. So what I'm doing is I'm removing that, just a little bit of that ligament. Now, that ligament, you don't really need, and removing this little bit doesn't make any difference here. If you do this kind of the traditional way, you've got to remove much more of this ligament, as well as oftentimes, typically bone, and maybe sometimes some of the joint, which can be a problem.
Yours is a special way so you don't have to move that much?
Yeah, mine's a special way so that, I can take care of these patients and they can get better much faster.
Mm-hmm.
Without so much pain. And so I'm just coming, just opening a little window so that I can get down, and underneath it you're going to see the nerves. And do you see? Here, I'll show you. See that yellow stuff in the front of the screen?
Yeah.
Deeper down?
Mm-hmm.
That's fat, actually.
Mm-hmm.
We call it epidural fat.
So there was also fat in the mushy stuff?
There's fat underneath the ligament. So the dura is like a water balloon that the nerves are in. And epidural means above the dura, so around the dura there's usually fat. We call that epidural fat.
And you have to get to the vessels.
I've got to get to the nerve, and I've got to get the piece of the disc that pushed out and is pushing on the nerve. And if there's any vessels in the way, I make sure that they don't bleed or anything like that.
And then you use the heat thing.
The cautery. And so what you can see is I can turn the camera, and the camera is at an angle, so I can see kind of around the corner. So now I'm looking a little bit back toward myself so that I can make sure that I get all the way the ligament, because what I'm trying to get is around the nerve. And that, on the left side of the screen, that was that epidural fat coming into the view. So after I remove this, we'll be able to see the nerve a little bit better. You're starting to see the nerve just a little bit.
What's the orange stuff under the white?
That orange stuff there? Yeah, that's the fat that I'm talking about. You're right. It's kind of orange, and the ligamentum is yellow. In fact, ligamentum flavum means yellow, so it means yellow ligament. And that orange stuff, you're right, that's the fat, and the nerve is right under there, so I have to be very careful. But the nice thing is, all of this is really big on my screen, so it's very safe, and I can see everything that I need to see.
And you have to get through the fat right there to get to the
nerve.
vessel,
to the nerve.
To the nerve.
And so you can see I use two hands. I use one hand to hold the camera,
and one hand to hold the tool.
The tool, that's right. And I watch the whole thing on this big screen.
Sometimes it gets close up, sometimes it gets far away.
Yeah, and so I can control that with how close I hold the camera to whatever I'm looking at.
Oh. So now it's far away?
Not far away.
But it looks far away.
Yep. So this is me using that cautery thing. So there was a little vessel that was bleeding just a little bit.
And then you use that heat, the cautery
to stop it.
And it's on electricity?
That's right. It works on electricity. And so now I'm using that tool not to do cautery, but I use it to gently move that fat.
Around.
I'm moving that fat around because what I'm trying to do is get around the nerve so that I can gently move the nerve out of the way.
Why does it go up, down?
Because I'm using it. That's my tool. It's like my hand, basically.
It's like a punchy tool?
It's like a tool to move the fat around. And see, now I'm using the grabber to remove some of that fat. And underneath that fat is going to be a white nerve.
And you want to get to there?
That's what I'm trying to get to. Because once I see the nerve...
I can kind of see it.
You see it underneath? Something white?
Yeah.
Once I get to there, I can gently move that nerve out of the way, and the disc is underneath it. The piece of disc that had come out and is pushing on her nerve. And this surgery is in real time, so this is actually how long it takes me to do it. I didn't edit this, I didn't take anything out. So, it takes about, half an hour, depending on the surgery.
Maybe even 3 hours.
It depends. That would be, a more involved surgery. But for a typical one like this, it usually doesn't take me more than an hour or so. Do you start to see that nerve coming into view underneath?
What's the red thing?
Good question. The red thing is there's usually tiny little blood vessels on the nerves. And so the red thing is one of those blood vessels.
You have to be careful around the nerves?
You do, because those nerves give people the ability to move their legs and feel their legs and everything like that. So I have to be very careful when I move the nerves around. So this is a tool that I use to gently free up the nerve. So you can see I went all the way to the side of the nerve, and I'm gently moving it back and forth.
Did you already use the tool?
Which tool?
This one that you're using?
No, good question. This is the first time that I'm using it so far in this case. And so what I did is I gently pushed my tube all the way down now, to where the nerve is. And that white thing at the top of the screen, that's the nerve. And so I'm using my cautery.
And that red thing, the red tunnel thing that I can see is the blood vessel?
The blood vessel on the nerve, that's exactly right. So I'm using my cautery just to make sure there's no blood vessels next to the nerve.
Is there 2 blood vessels?
There were 2 blood vessels, exactly right. This is how I hold it. And you can see the water dripping down my fingers because there's water constantly pumping through. In fact, I wear special shoe covers, booties over my shoes, because sometimes the water drips down on my feet.
And so it doesn't get under your socks?
That's right. So right now I'm just making sure there's no blood vessels in the way. And there's the nerve. You see that white nerve at the top?
Mm-hmm.
That's the one that goes to the patients down the back of their leg, down their calf, and gives the muscle strength to their calf so they can stand on their tiptoes. It's called the S1 nerve.
And that part's hurting?
That is getting, you'll see there's a big disc herniation like we saw in the MRI that's pushing on that nerve and pushing it out of the way. And so what I'm doing now is I'm just cleaning up everything just to the side of the nerve. And that disc herniation is going to be evident. You're going to see it right underneath. So see that white thing right in the middle of the screen?
Yeah.
There's the white stuff. That is the disc bulge under the nerve. So what I did was I turned around my working tube there, and the tube is beveled. So it's got a what we call a tine that sticks out a little bit more on one end, and that allows me to retract, or another word for that is move structures out of the way. And so what I did was I turned that tine so that it moved gently that nerve out of the way, and now all we're seeing there is the fat, that epidural fat that I told you about, as well as a big disc bulge underneath.
What are those bubbles that I saw on the camera?
Good question. So when I use that cautery, it makes bubbles. And so sometimes they bubble up. So really what I'm just doing is I'm just cleaning everything up so that I can see that disc herniation underneath.
Now I can see way more blood vessels than 2.
That's right. And there are blood vessels on the floor of what we call the canal. They're called epidural vessels because they're around the dura too.
I can see big ones and small ones.
Yep. And so I like to cauterize those. You'll see I'm going to make sure that they don't bleed. So I'm cauterizing them. There's the bubbles that you saw.
Mm-hmm.
What do you think? You want to do this when you grow up?
Yeah.
So see that all that white stuff there? That was the disc. So I'm just getting everything ready because what I'm ultimately going to do is remove that disc bulge. And you see there's the nerve. I just rotated it and the nerve came back down. So see how that disc was right underneath that nerve and pushing up against the nerve?
So the disc is pushing on the nerve?
And that's what's causing her pain. That's exactly right.
In her leg?
In her leg. See how that nerve is stretched tight over that disc bulge? We're gonna take care of that, right? And help her feel better?
And you're gonna take it out without touching the
blood
vessels?
Or the nerve, because I gotta be very careful around the nerve. Now, I don't take out the whole disc.
But some of it, the part that's stretching over it.
That's right. I only take out the part that has come out. Because she needs that disc, hopefully, the rest of the disc for the rest of her life. But the part that's come out, there's no way to push it back in and make it stay. So what I do is I just remove the parts that's come out and is not helping her anymore, and I leave the rest in place.
And it's just hurting her.
It's just hurting her, that's right. So it's not doing her any favor. So we just removed that part, but I'm very careful not to remove too much. Now what I'm doing here is I'm just going to make a little opening in the outside of that disc. And what you can see is, oh my goodness, do you see it? There's disc underneath. And it wants to come out. See that?
Yeah.
That is that big disc bulge. So I just kind of pushed down a little bit on that tube, and that disc bulge was under so much pressure that when I opened up that area, you could see it just kind of erupted out.
Yeah. It exploded like a volcano.
Like a volcano, exactly. And so now I take a grasper, and I can remove those pieces.
Some of it?
Yeah, just the stuff that's come out. And you see how I'm rolling the tool?
Yeah, so it like twists
it.
And it can't stick anymore.
That's right. So I can get it out, in one piece or a number of larger pieces. And watch this. So sometimes it's so big that I can't pull it out of the top of my camera. I've got to pull it out with the camera. And what you can see
why
is...
does it look like it's on fire?
Well, that's just because of the light. But you see that big piece of disc hanging there?
Mm-hmm.
That is what was torturing this lady. So we remove that, and I can just imagine her leg feeling so much better, saying, it feels so much better.
But why isn't that over yet?
Well, that was most of the surgery, but I got to make sure that I got it all out. So sometimes it'll come out in one big piece like that, but then there will be other pieces left. So I got to make sure that I don't leave anything behind. So see, there is a little bit there.
Yeah.
There it is. And that, you see that hole there? That's that little hole that piece had come out of. And so I'm just going to feel around and make sure that there's no additional pieces of disc. Because the last thing I want is...
Under it?
Exactly right. I don't want her to wake up and go home and then more disc comes out. So I just gently feel around and make sure that there's nothing else left that might be coming out to hurt her.
Uh-huh.
And we always save those pieces of disc because it helps me figure out if I've gotten everything that I think I've gotten. So I save those pieces of disc on the back table there, and then I can look back and say, hey, looks like I got about as much as I would have expected. So now I'm using the cautery because did you see there's those veins there?
Uh-huh. Daddy, what happens if you have to take all of it out?
Oh, very good question. Well, I don't have to ever take all of it out. The disc is actually a very big thing, but the area for the nerves is not very big. So even in a big disc herniation that's really crushing the nerves, even when I take out that disc herniation, the patient still has the majority of their disc left. So because the disc is such a big thing. What I'm doing now is I'm using that cautery to shrink down that tissue and hopefully seal up that hole a little bit. And so I let that nerve slide back into view. You see the nerve?
Yeah.
And you can see there's a little bit more space there. That's me with my camera on my head. And so now I'm really just assessing, hey, am I done or not? And there's a couple different ways I can figure that out. One is I look. Two, with the camera. Two, I feel, and I make sure that the nerve is nice and loose. See how I can easily push the nerve out of the way now?
Yeah, is that tunnel thing that is that the camera?
That's the working cannula, yeah. So now it's much easier to move the nerve out of the way. And I always do lots of double checks to make sure that we've gotten everything. And I can feel, so I use this probe to feel. I'm feeling the back of the bone there. And I want to make sure that there's no disc pushing beyond the area of the back of the bone. So I felt the bone above, and now I'm feeling the bone below. And you can see that the disc, which is what's in between, none of that is pushing up beyond where I was feeling. So that makes me more confident that there's no more disc herniation pushing on the nerve anymore. And you can see how easy I can push that nerve out of the way.
Uh-huh.
And sometimes I'll find other little pieces. I just want to make sure that we get it all out.
Sometimes you can find like little pieces once you think you're done.
Yeah, sometimes you think you're done and you look around the corner or you feel underneath something and another piece comes out. So I really take my time and I make sure that before we leave the operating room that I'm very confident that I've gotten all the disc out that needs to come out. But again, it's a balance because I don't want to take
all of it out.
All of it out. I don't want to take disc that she needs. But here I found a little bit more. So I'm removing that. But we're getting close to being done.
Because I can see you're not grabbing that much out.
That's right. There's no more big pieces like that. That first big piece was the biggest one.
Yeah. But once that you pulled it out, it actually looks pretty small.
It looks pretty small. That's what I was saying. So the area for the nerves is pretty small. But, even something that looks pretty small can cause people a lot of pain. Sometimes people are in so much pain from these that they can't walk, they can't sleep, they can't work or go to school. And sometimes they're even weak, so their muscles don't work.
Daddy, how do they get there? If they can't walk, they can't push the pedals on the car.
Yeah, sometimes somebody has to drive them. And, the other question is, why does this happen? And some people, it just happens.
How does it happen?
Yeah, some people are in like an accident, and a lot of patients think that you have to be in a car accident or something like that. But really, most people, this just kind of happens out of nowhere. And it happens in everyone from teenagers to older people.
Sometimes even kids?
Less likely in kids, but in people in their teens or in 20s and 30s and 40s and 50s and even beyond, they can get disc herniations. And most of the time, it just comes out of nowhere. Disc problems sometimes run in families. So sometimes a lot of members of the same family will have a tendency to get back problems and disc problems. And sometimes that's the case, but most of the time this just kind of comes out of nowhere. But the good news is we can help these patients feel a lot better, and they don't need a big surgery in order to make that happen.
Yeah.
So that's the disc material. It's pretty big, almost 2 inches. And the whole area for the nerves is about the diameter of like my thumb. So it's not that big. So you imagine if all that stuff was shoved in an area the size of my thumb all the way over on the one side, that would not be a lot more space for the nerves.
Why on the ruler? Why did it go to 4 and not 2?
Oh, good question. The one side was centimeters and one side was inches.
And it was on centimeters?
That was the centimeters. On the inches side, it was about 2 inches. So now I'm just cleaning everything up with the cautery, making sure there's no little pieces hiding anywhere.
So you're just kind of moving it around?
Moving around, trying to seal up the area, making sure there's no bleeding, because I got to make sure that there's no, vessels that are bleeding before we are finished in the operating room. And soon we'll be doing some checks, other checks. So here you can see the nerve, and before, remember how that disc was really pushing up against it, and now you can see there's space underneath it.
Yeah, there's like a couple inches.
Yeah, and you can see there's a shadow under it too. And before there wasn't a shadow because that disc was pushed right up against it. So now what we're going to... sorry.
There was disc under disc?
There was disc under the nerve before. Bulging disc. Now there's still disc there. That's where it's supposed to be. But it's not pushing up. So what I do here is I'm going to do some additional checks. So I take some x-rays to make sure that I've cleaned out everywhere where I know that I need to be. So you can see I put that probe all the way down below the disc space. And then I turn it around and I'm going to go above the disc space. I'm feeling. Above the disc space, and I can feel, and there's no pressure there. And I'll take an x-ray just to confirm. And what you're going to see how I can feel all the way up to the top there. That's way above where the disc herniation was. So I know that there's nothing there. And then I'm going to take a last x-ray with me showing how far toward the middle I can get. So what I'm going to do is, in a second, I'm going to rotate the nerve out of the way, and then I'm going to go kind of toward the middle, and we'll take an x-ray and show that, her symptoms were only on the right, but I was able to reach, you can see, all the way over toward the left side.
Why is everything blowing up?
The fluid, because the fluid is pumping through, and then it comes out from my camera. But we'll take an x-ray here, and you'll see I can get all the way from the right side toward the middle, and you can even get over to the other side if you need to. But she didn't have any left-sided problems, so I stayed only on the right side in this one. But you can clean out both sides just from one side. And you can see I can go all the way toward the middle there, which is plenty far for where her problem was.
Uh-huh.
We put the lights back on, because I'm pretty much done.
You don't have to see the screen anymore.
Not as much. So that's that happy nerve.
Mm-hmm.
You think she's going to feel better?
Uh-huh.
She felt so much better. So much better. So now what I do is I make sure there's no more bleeding left, because you don't want blood to build up in that area when you're done. And so what I'm doing is I'm pushing in a medicine called thrombin that stops any bleeding that's left.
So you don't want the blood to come out and shoot up?
No, I don't. I certainly don't want that. And also, if you don't stop the bleeding, or any little bit of bleeding, sometimes in frequent cases, that blood can build up and push on the nerves afterwards. So I make sure, you can see, I turn the water fluid off, and you can see that there's not, significant bleeding or anything like that. And as long as you're careful, that doesn't tend to be a problem. See that pulsation? See how everything's kind of pulsating there?
Uh-huh.
That's actually the nerves and the what we call the dura. They pulsate because there's some flow of the fluid inside of them. So I know that when I see that pulsations, that's another check to show me that I'm done. I'm just coming out. That was the hole, remember? That little area that I made in the ligamentum flavum.
Now it's kind of getting squished.
Oh, nothing's getting squished anymore. I take the camera out, and now we close everything up. So I actually use a needle and thread, special needle and thread.
Why could you not see as much hole when on not the last one but the one before? Why could you see not that much of the hole?
Probably because I was pulling my camera out.
Oh.
But now I put a couple stitches underneath the skin, nothing on the outside, and then on top of it we put a special glue.
Why do you put glue on it?
I put glue on it so they don't need any stitches on the outside, and the glue is pretty much waterproof.
Huh? So
Yeah.
they can go swimming in a couple weeks?
They can, once the incision heals, they can swim, but even before that, they can shower really quickly after this. So like they can shower on the day of surgery because this glue is pretty much waterproof.
What happens if you have to stay at the... What happens if you have to stay at the hospital?
Oh, these patients tend to go home within a couple hours. So you can see she was home within 80 minutes, so less than an hour and a half. And her leg pain felt so much better. And she didn't take any narcotic prescription pain medications. She went like right back to work. So, most patients are back at work within a day or two of surgery. Well, let's do a sign off.
What's a sign off?
Well,
everything else was good.
It was great. You did a great job. So let's say this. Well, thank you for joining us. It was nice talking through all of this stuff. Here's all my information. I'm always available for a consultation if anyone has any questions. And Noah, thanks for being my co-host today. Did you have a good time?
Yeah.
And what do you think about spine surgery?
Good.
Good. All right. 2 thumbs up. Thank you, everyone.